Okay, good afternoon. You're almost there. Okay. Now, I won't introduce myself because I've already done that, but um, what I'm going to talk to you about is some of the changes that have happened in death determination. There's been reference already by Dave Harriman and about the alphabet soup of different things that we use, and try to build some rationale for why it's happened, for better or worse. I have no conflicts of interest other than my position with BC Transplant as far as this topic. So what I hope to do is provide some sort of background for why these changes, specifically in nomenclature, have taken, because it is a bit of a pain, and I had no idea how much work went into changing the short forms of different causes of death. All our policies had to be changed, and all the health authority policies, and so apologies to all, but that's sort of what happened. So I'll introduce the new nomenclature, acronyms, and a rationale for that. And also, in addition to just the way things are named, more importantly and relevant is just some of the changes that there have been made to the change into how we actually declare death. And this all sort of originated from this article and a whole bunch of supplementary articles. And one thing in Canada we can be proud of is probably Sam Shemy. Sam Shemy is a pediatric intensivist. He's a consultant with Canadian Blood Services. He's been involved in many projects there, initiated them. He is internationally renowned as far as death determination. He's done work with large groups internationally. And he and a large number of others in Canada got together to create these guidelines. And he's also been behind just the thinking of trying to have a more consistent approach to how we declare death. So this came out in May in the journal, a Canadian Journal of Anesthesia. There was the guideline document, and then there are numerous supplemental ones. The amount of work that went into this and the output is really quite something. There's been reference made to the dead donor rule. Dr. Harriman was talking about this. The dead donor rule we do use. It is a rule that we follow, and it's a fairly simple in concept. Is that we do not take organs from somebody until they're dead. And this may seem like a no-brainer, but there are countries, places where people have died because of donation. And so in a broader sense, it is based on ethical norms to protect donors. In this dead donor rule, the idea of brain death is included as being dead. But it's important to understand, and you may be aware of this, that not everybody believes this. More and more you're seeing in ICUs, families who don't believe people are dead when we say they're dead because of their brain injury, and still insist on the idea that the heart is going and that they're not dead. And even within the medical community, the healthcare community, there are others who also don't believe, and very quite prominent people stand up and say it's somewhat arbitrary what you've come up with, these criteria. So these Canadian guidelines, one thing that just to sort of set a premise as to why some of the decisions were made for some of the things that they say need to be done, is that they really value specificity of diagnosis over sensitivity. And I know if you're like me, I always have to stop and try to think, what does that really mean, right? Sensitivity, specificity. But in this case, specificity is patients that are diagnosed as not dead are really not dead. So you'd never want to, and I hope I got this right, you never want to clearly say somebody's dead who isn't. So and we know with diagnostic tests of any type, there's always some potential trade-off of sensitivity for specificity. So they will always look towards something being more specific, or even appear more specific, because of the concern that we need to be consistent, ideally across our nation at least, in how we say somebody is dead. So there's enough people who are questioning it that we have to ensure that. So wherever evidence is scarce, and in this area a lot of times the evidence is very weak or non-existent, and when you have guidelines, the default then tends to be more to expert opinion, that they tend to be a shift towards making things more conservative. Anything they think that might interfere with the assessment of brain death, they tended to pick things that are a little bit more conservative than before. Now, historically, people were dead when their heart stopped breathing, and that's been there always. The initial transplant or heart transplant was done with somebody who died of cardiac death in South Africa by Dr. Bernard. Brain death was first defined in 1968 and really was to help facilitate the idea that somebody has such a bad brain injury they're never going to get better, and yes, they can be an organ donor. And this was by the ad hoc Harvard Medical School committee of the Harvard Medical School. But as I mentioned, there is controversy in death declaration. The concept of brain death continues to be challenged and more frequently than it used to be. Donation after withdrawal life support was also challenged, what we used to call DCD. It seems odd maybe now to know back in 2006 or when they came out with the guidelines leading up to that, there was still a lot of controversy, and even afterwards, some provinces were, I shouldn't say slower, but weren't as ready to implement it. And so, led by Sam and others, there was this feeling and need to think more about the whole idea, like, when are you dead? What makes you dead? Is it your heart stopping? Is that what makes you dead? And the move from this group, I think, logically, is that I'm dead when my brain's dead. The fact that my brain is working is how I manage to stand here doing whatever I'm doing right now. So we're trying to focus on a brain-based definition of death, and that's really what they've come up with. And so this is the criteria that in order to be dead, there has to be a permanent cessation of brain function. And what that means, sort of clinically, is there's an absence of any form of consciousness, and an absence of brainstem reflexes, including the ability to breathe spontaneously. And this can result from either a cessation of blood flow to the brain, when we withdraw life support, or with a devastating brain injury. So again, the change in the actual letters that we use was to try to get to be more consistent, I think, just so everything kind of fits together, and as opposed to a little bit not quite the same if you're looking at circulatory death versus NDD or whatever. So there has also been an evolution thinking about how you define DCD. When DCD came out, it stood for donation after cardiac death. The focus was the heart. And the heart stops, which makes sense. But as folks started thinking more on it, is it the heart actually stopping? Like, or more the consequences of the heart stopping? And this is, again, if you're going to try to unify it and to say it's the brain that counts. So the circulation stopping, and specifically the circulation going to the brain, is what's probably most important. NDD and DCD are not equivalent. They don't mean exactly the same thing, but one's brain death and one's the other. I mean, NDD is the neurological death declaration of death. That's what it stands for. It has nothing to do directly with donation. It doesn't mean that, as opposed to DCD, which is donation after circulatory death. So you really need to add donation after NDD or to be equivalent to what DCD was. So they weren't quite the same, and when we started changing the nomenclature, there was a bit of confusion because people would plug in the new one, DCC, that I'll come to, for DCD, which is not quite the same. So again, a little bit confusing. The US has adopted, I think most widely, DBD, donation after brain death, and DCD, donation after circulatory death. And actually that makes a lot of sense to me, those ones. I mean, they're simple, straightforward. But in Canada, this group, and it sort of came with slightly different thing. They're focusing the guidelines on death determination. So they were looking at death determination by neurological criteria being equivalent to brain death, NDD. And then there's no really equivalent to DCD coming out of this. So it's death determination by circulatory criteria. So these are both all about death determination. And so you really have to add donation after these new terms. So I apologize for things that may seem a little bit more confusing, but just to be aware so this is where we are. There's donation after DNC, and there's donation after DCC, and then there's also, as you know, donation after May. And I honestly don't care what you use, whatever you use, go for it. But this is just trying to explain this terminology that you'll start seeing more and more coming from us or elsewhere and what they mean. So, and whether they get changed sometime in the future, who knows? That does happen. I'm just going to sort of switch gears now and just talk about some of the things that have changed from the guidelines as far as how we go about death declaration. And the first one I've already really talked about. The second, and a few of these ones are really intuitive, and I think were implicitly part of it, but now they're more being explicitly stated in the guidelines. So this idea that when somebody is going to be, if we're looking at brain death specifically, there has to be a clinical scenario that's compatible with it. There has to be something you could say, oh yeah, I can understand how this person may become or be brain dead. And in addition to just the scenario, there needs to be some neuroimaging, radiologic imaging that is consistent with it. So we generally CT scans, sometimes also MRIs that show that there's such a bad injury to the brain that we can understand this person may be brain dead. So that was just being more explicitly said. And this hasn't really changed practice, I think, but it just makes sense to say it more explicitly. The second one is also something that I think is pretty much what we would do. In the UK, brain death is really a focus on the brain stem and death. So there's some differences of opinion because you can have isolated brain stem injuries that will make you appear on clinical criteria to be brain dead. So you have no apparent consciousness that we can see because you're kind of locked in, can't do anything. You have no brainstem reflexes, you cannot breathe, and yet you can have consciousness. And so this is something that the guidelines just wanted to explicitly recognize that in the case where you have what appears to be a brainstem injury, no clear on imaging enough damage above there to say that this person couldn't be conscious, that we would not say that they're brain dead. So in that context, you could proceed with donation after death by circulatory criteria, and that's generally what happens. Now, many of these patients, because of the injury, they may have secondary hydrocephalus and go on to actually become brain dead, but this is just something that they want to explicitly state, but was really sort of how we practiced before. The other ones, these are more minor things, but previously, in the previous guidelines, patients had to have a temperature of greater than 34 degrees Celsius. The 36 degrees Celsius is not based on anything other than the general philosophy as maybe be less than that, you might call somebody brain dead who isn't. But there's no studies, there's no evidence to support that. So it's just, as a group, they got together and got quite conservative, and it's not a big deal for us to, sometimes we have to warm people up a little bit prior to it, but previously, if somebody came in with the sort of cardiac arrest that used to be the most common type that we would see, in other words, primary cardiac. These days, as far as donation is concerned, the type of arrest we see is usually secondary to a toxic drug ingestion, which is somewhat different because there's a prolonged hypoxia from hypoventilation prior to the arrest. So the brain injuries are always much worse in those contexts. But it used to be if somebody came in with a cardiac arrest and they weren't waking up at 24 hours, that you can go ahead and start looking at examining them clinically. And the caveat here is that usually they came in and had a CT scan or that showed not much change, because when you have a primary cardiac arrest, you usually have quite relatively brief resuscitations compared to the context of a primary respiratory arrest, and you may not see changes on the CT scan initially, or very minimal changes. So in that context, they said you really should wait 48 hours of not waking up before you go ahead and do investigations. Now, this does not apply to the person who has a really, really bad looking CT scan when they come in. So the toxic drug ingestion, there's other confounding things going on, but their scans will often look very bad on presentation, and that's not what this is referring to. This is one that's scanned as non-diagnostic and then the other thing you can do is you can repeat the scan. So it doesn't mean, oh, you now have to wait 48 hours, you can't do anything. You can repeat the scan the next day if you wish, whenever, as frequently as you, and if the scan looks bad, then you can go ahead. You don't have to wait the full 48 hours. I'm not going to go into too much detail there, but apnea testing is an integral part of death declaration for neurologic criteria, and it's really trying to show that as the carbon dioxide level goes up to a certain level or above a certain level, which would make all of us incredibly uncomfortable and breathe very fast, that there's no response. And usually, in the past, we've let that happen passively. The patient is disconnected or taken off the ventilator. They're given oxygen, pre-oxygenated, because you don't want them to become hypoxic during it, because then you have to stop. And then you just allow them time for their CO2 to get to a target level, and sometimes you're just guessing, and you do a blood gas. There are now ways that you can look at trying to do it somewhat differently. One way that's becoming quite popular is passive, like hypoventilation. So instead of taking somebody off the ventilator, you just decrease the minute ventilation, so their CO2 will rise, and you can watch their end tidal CO2, check the blood gas, and when they're in the target range, then you just have to take them off for a minute and see whether they don't breathe. So it requires a little bit more preparation, but it's certainly clinically a lot easier to just look at somebody and see whether they breathe for a minute rather than having to wait 10, 20 minutes sometimes, depending. There is a potential to administer CO2 exogenously. Probably that will not be used very much here, because and the time of death, again, this is not too much different, but we know for patients who die as a result of circulatory criteria or by circulatory criteria, it's clearly after they have 5 minutes of hands off. And for the death by determination by neurologic criteria, if there's no ancillary testing involved, which is always the preferred thing, not to do ancillary testing, it's the apnea test, as you know, like the second blood gas that proves that they actually. And then if you do need an ancillary test, the timing of death is the time that the ancillary test was completed. All right, and this is really the last thing I'm going to have to add, really, is for donation after DCC, we have this 5 minutes hands-off period, as you probably heard. So a patient becomes asystolic, or in ICUs, generally we're looking at the pulse pressure, and if it's less than 5, that's when we can start the 5 minute, and after 5 minutes, if there's no return of resuscitation, then the patient is deemed to be dead. Now, in the past, in many institutions, I think the majority of them, because the ICU was a little distance, or sometimes more than a little distance from the OR, that there would be a movement of the patients. So after a couple minutes, they have them packed up, and they just start moving to try to more often get to the OR by 5 minutes, and then do the final declaration there. So this has been generally, we've been advised and recommend not to do this. And again, this comes down to the idea of not wanting to miss somebody or calling somebody dead. It isn't, and specifically, perhaps not, missing an auto resuscitation while we're moving people down the hall, that we may not notice when somebody's blood pressure returns or heartbeat return. Yeah, and so that's the only real change. And I just thought I'd sort of make a reference to this concept of permanence versus irreversible, because in the context of patient death determination by circulatory criteria, it's not necessarily something that's irreversible in the sense that if you try to resuscitate that person, you probably could, because they've just died. But the idea that it is permanent because there is going to be no resuscitation, and the patient and the family does not want resuscitation. So it's just to be clear that some people will say, well, it's not irreversible, but no, we're not trying to say it is. What we're saying is after 5 minutes, the heart's not going to start on its own, and that's been well shown in the studies. So that's really all I had to cover, and just trying to hopefully make that clear as to why these changes are made. There, in my lifetime, there may be further ones, and also just some of the changes in approach to how we declare death. That's all I got. Thank you. And there may not be any questions, which means I've been very, very clear. Or you're all asleep. Okay, yeah. I think that's all I have then. Are there? Oh, you're right. Okay, all right. Does the use of NRP change how death declaration should be made? No. Because NRP starts after somebody's been declared dead. This is not an intervention prior to when somebody's still alive. So you go through the same, so that they go through the same 5 minutes to declare death, and then they move, and it's going to be interesting to see because right now death declaration happens in ICUs generally, or sometimes recovery rooms in BC, not in ORs. I'm not sure how VGH is going to start their NRP, whether they will have consent to do that, but okay. And okay. Did the group working on revised definitions consider or discuss how brain death is described and communicated to families? It is very clinical and confusing. I think they basically considered everything, and there are companion documents. Peggy is part of CBS, who sort of really sponsored and supported this. So there's lots of information there. There's on the webpage and collateral ones. I don't know, Peggy, if you have anything particular you want to talk to there.
I would also add that work is underway in terms of providing additional supports and tools for families, so that's still a work in progress.
And then there's a question here, when is the new criteria going to be specifically enacted? For example, right now we still have temperature greater than 34 and 36, so soon. We've had a few things that, as we previously mentioned, in the context of MAID, what we have many nurse practitioners who are MAID providers, and I had the frustrations and of not being able to declare death in the context of organ donation, where they do all the time when it's not there, and so it doesn't make sense. So that is coming in, but all these policies are being changed, but we're kind of waiting for the sort of final steps to get the go ahead, and so once that happens, we didn't want to change part of it and then have to go back and change everything again. So in the meantime, we're encouraging people to, it's okay right now. I can't say you have to have them 36 degrees, but if you want to start doing it that way, do it that way. I don't think it's going to make any real difference, honestly, but it will probably, we'll see this sort of later in the summer, certainly by fall. Hopefully we'll have everything in place. Okay. What kind of training will be provided provincially to ensure all sites in BC are aware? Then everything just disappeared here. As you're aware, we have in-hospital coordinators who aren't necessarily always in hospital, but they are assigned to different hospitals, and they are already working with groups there to provide that education, and there obviously will be more once the policies and things all become in place. So, is there a BC transplant reference document regarding criteria for declaring death? Again, this is in the works. So, like, we have SOPs and things like that being worked on, and Julian and the quality group ended up doing a massive amount of having to redo so many of our SOPs because of the terminology. So. I don't think anybody ever envisioned this when they said, let's just call it this, and how much it's going to do. Will revised definitions be standard across the province and country? So the province, for sure. The country, TGLN has already made the change. Quebec has made the change. So within the world of donation right now, that's what we see. So I imagine the rest are going to follow as well, but that's... Now, as far as internationally, I don't think that's necessarily going to happen, but this is where we are. Okay. And unless there's any